We decided to evaluate the HOP test versus Cincinnati knee rating system for assessing return to sport post-ACL reconstruction. Evaluating readiness to return to sport is important for preventing re-injury in athletes. Strength, pain, range of motion, and psychological preparedness are taken into account when determining if an athlete is ready to return to sport. The HOP test includes 4 different style hops: a single hop for distance, a 6-meter time top, a triple hop for distance, and a crossover hop for distance, in that order. Extra information regarding the details of the different hop tests are in the upcoming slides. Feel free to pause the presentation and read at your leisure. For the overall combination of hop tests, the ICC was 0.93, which is excellent relative reliability. A good ICC is a value greater than 0.75, and for clinical measures, you want an ICC of higher than 0.9. The standard error of measure is a plus or minus 3.04%, which was found using the upper 95th percentile confidence interval. This is considered an absolute measure of reliability. The error in an individual's limb symmetry index score could vary plus or minus 4.99% at any point in time due to measurement error.
The authors studied construct validity using the known groups method and compared between operated versus non-operated limbs on each of the 4 hop tests using paired t-tests. Changes in absolute scores for hop tests on the operative limb were statistically greater than changes on the non-operative limb. The authors also studied construct validity using convergence. This is based on the construct that change in limb symmetry index scores should be at least moderately correlated to changes in scores on self-report measures. The study evaluated the correlation between change in limb symmetry index scores and 1. Change in the LEFS, and 2. The global rating of change. They found that validity was R equals 0.58 with GROC, and R equals 0.41 with the LEFS. The results indicate that the GROC is most highly correlated to overall LSI and has good validity. The authors studied responsiveness using MDC. They found differing values of change for the reconstructed and non-operative limb. An MDC of 12.96% for the ACL reconstructed limb would mean that patient would need to demonstrate a 12.96% change in LSI to be considered true change. One-legged function tests had low sensitivity. Therefore, the test is not able to reliably identify true positives. For example, a patient who scores well on the single-leg hop test cannot be confirmed to have adequate dynamic knee stability to return to sport. The hop test did, however, have high specificity, meaning that these tests can be used to confirm abnormal limb symmetry. In terms of feasibility, pros of the test include minimal equipment is needed to conduct the tests. They are not very time-consuming. They don't require any specific training. And lastly, they are simple tests that don't require advanced cognition on the patient's end. Cons of the test include they are somewhat dependent on the patient's condition that day. They require patient coordination. And lastly, they require open space. The hop test is used to evaluate progress in knee rehabilitation programs. Because of the level of impact required by the test, the hop test is administered when the PT deems the patient capable of handling that impact. PTs may administer the hop test before an exhaustion protocol to assess an athlete's hop symmetry when not fatigued, and subsequently the PT can have the patient complete the hop test after working out. This protocol would give further information about an athlete's readiness to return to sport.
Most people are familiar with the HOP test as a common tool for assessing readiness to return to sport after an ACL reconstruction. However, in recent decades, there has been a shift in focus regarding determinants of successful outcomes after ACL injury. While previous methods like the HOP test relied on measures of physical performance, a patient-centered approach is now emphasized. The Cincinnati Knee Rating Scale was developed to assess subjective symptoms and activity limitations after ACL injury and reconstruction. It includes an assessment of pain, swelling, activity level, walking, and sports-related movements. Once completed, the CKRS is graded on a 100-point scale. The CKRS showed high test-retest reliability overall, with an ICC greater than 0.75 in the reconstructed ACL. The ICC coefficients of the individual subscales also showed high test-retest reliability, with coefficients ranging from 0.75 to 0.98.
Two types of validity were studied, construct and content validity. In terms of content validity, the CKRS showed no floor or ceiling effects before surgery, but at follow-up, a limited floor effect was noted in the sports-related subscale, as 24 patients, which was 10% of the participants, obtained the worst possible score. Lastly, the CKRS had good construct validity, as 8 of the 9 hypotheses were confirmed. The authors found that the CKRS was highly responsive to detecting change between the pre-op eval and follow-up evaluations. Results show that 7 of the 8 categories had large effects, ranging from 1.07 to 2.48. The remaining category, which was activities of daily living, had a moderate effect of 0.72. The effect size was determined using the Cohen standard. Pros of using the CKRS include that no physical effort is required by the patient, the score is quickly calculated, and it's easy to administer. The cons are that the patient must be able to read and understand the questions on the form, and there's a chance of self-report bias. The CKRS is used for patients with knee problems or after knee surgery to assess a patient's perception of his or her function and is used to track patients' progress throughout the course of PT. The CKRS may be given pre-op, post-op, pre-PT, and post-PT. This slide gives a summary of the psychometric properties of each measure. Key take-home points from what we learned are: a limitation of the HOP test is the test's low sensitivity. If a patient completes the test and is deemed to have no limb deficiency, the assessor cannot be sure that this patient is ready to return to sport. This is a problem because a PT will not want to send a patient back to sport before the patient can return safely. Despite this limitation, we would choose to use the HOP test over the CKRS in evaluating a patient's readiness to return to sport. The HOP test is not subject to self-report bias, and for patients who are very eager to return to sport, self-report bias could be a factor in that patient's CKRS score. We think the best way to test how a patient will physically perform when returning to sport is to directly evaluate physical performance. However, both measures can be easily implemented in the clinic, and the CKRS has its strengths in being able to assess progress through therapy, but progress is not necessarily what we are looking at when evaluating return to sport readiness.